Hello, and welcome to another podcast of WeNap. Today we're going to discuss geriatric anesthesia. My name is Michael Burns. I'm an assistant professor at Webster University in St. Louis, Missouri. I've been a CRNA for about 22 years, and welcome to WeNap. These podcasts are intended for SRNAs, CRNAs, physicians, RNs, respiratory therapists, paramedics, anyone. Really, the only intention is just to improve patient care. Some of the SRNAs may use it for preparation for their clinical sites, or maybe in some topics in their classes that they're currently enrolled in. Basically, just anyone's welcome to listen to our podcast. So geriatrics, I thought it'd be fitting. I just had my 50th birthday. So I thought we'd start off our first podcast with airway, which is obviously extremely important in anesthesia management, and then kind of fitting to move on to geriatric anesthesia. So a few topics that we're going to discuss is preoperative assessment, age-related anatomical and physiological changes. Seems to be a heavy area that's tested on the board exam. We'll speak a little bit about delirium and some age-related pharmacological changes. Again, more of a heavier board exam topic. What about similarities between elderly and infants? Kind of the extremes in ages seem to give us a little bit of anxiety with anesthesia. So some of the similarities, they have a decreased ability to increase the heart rate in response to hypovolemia, hypotension, and hypoxia. They have decreased lung compliance. They have decreased oxygen tensions. They have impaired cough, and they're susceptible to hypothermia, as well as some decreased renal tubular function. About preoperative assessment. And this is, in addition to your usual preoperative assessment of a patient, we should look at their cognitive ability. It's pretty hard to tell if they've had some cognitive changes if we don't really know their baseline. And it's very helpful if they have a family member to kind of help us validate some of the information. Again, assessing for delirium, looking for alcoholism, substance abuse, and depression. In this patient population, it could be quite prevalent. Cardiopulmonary disease, functional status, and fall history. We think of someone having a fall that fractured their hip. And then we also think about if they're going to fall post-operatively, either after like a total knee or even a corrective hip surgery. Medication lists. Check out for polypharmacy. Lots of interactions with, drug interactions noted. Certainly polypharmacy could give us some issues with predicting a satisfactory emergence time. Treatment goals. And this is a big one. When patients come in for elective surgery, some of our more geriatric patients, and everyone's like, well, I'm okay if I don't survive the surgery. I was like, you're very likely to survive the surgery. The thing is what is your goal at the end of this? What is the functional status that you're wishing for? And what's the likelihood of you being discharged back to your independent home and live independently? And then when you start talking about, the need of potentially a nursing home or acute rehab facility, sometimes they lose interest in some of the elective surgeries. And this is an important topic to handle up front with the patients, especially if it's elective surgery. Family and support systems. Who's gonna be home with you? Who's gonna help take care of you? Who's gonna help assist you, with ambulation throughout the facility, and also, making sure that you're nice and safe at home post-operatively. Some recommended preoperative testing, hemoglobin, especially if there's significant blood loss risk or preoperative anemia. Renal function tests, especially if they're diabetic, hypertensive, cardiovascular disease, ACE inhibitors, or non-steroidal anti-inflammatory drugs. A lot of these patients coming in for osteoarthritic type surgical procedures have some coexisting disease, but they also have been treating their pain with non-steroidal anti-inflammatory drugs, and could have a negative impact on their renal function. Bowel albumin, if they have chronic or even a recent major illness, and check out for liver issues as well. Malnutrition is a great screen for that as well. Cognitive assessment, there's all sorts of tools to to assess someone's cognitive ability preoperatively. This is just an example of one where you give them a 3-word registration, and then they basically recall that for you, clock drawing, and see what their score is preoperatively to be able to really assess for any kind of changes that may have occurred during the intraoperative and postoperative period. Frailty score. Again, this is important to see if you're going to be discharged home and independently, or if you'll need some sort of assistive living arrangements. Also, indication for morbidity and mortality related to their frailty score. So you look at weakness, slowness, low level of functional activity, in which exhaustion, poor endurance is also the kind of their activity level, and weight loss. If they've had some unintentional weight loss, that could be an indicator of frailty. Let's talk about some age-related anatomical and physiological changes. Cardiovascular, they have decreased arterial elasticity. They have increased systolic blood pressure. They have an elevated afterload, and they're more likely to have left ventricular hypertrophy. And they have a decreased adrenergic activity, which means they have a decrease in resting heart rate, and they have a decrease in baroreceptor reflex. The respiratory changes that occur, again, these are pretty heavily tested on your board exam. Seems like pretty hot topics because of our aging population. Certainly, we're all going to be, geriatric specialists. Respiratory changes could be a decrease in pulmonary elasticity, and that's going to lead to a decrease in alveolar surface area, increased residual volume, and increased closing capacity, and ventilation to perfusion mismatching. And let's stop and talk about increased closing capacity. So as that number increases, remember, closing capacity is the volume in which the alveoli start to close. So if you have an increased closing capacity and your FRC drops, you're basically going to have alveolar closure. And so atelectasis, and certainly they're predisposed for that. And so you really should think about that as you're assessing your patient, is that, as their closing capacity increases and their FRC decreases, if that's below that, then basically the patient's going to be in a alveolar closing type environment and atelectasis. Increased chest wall rigidity is another change in their respiratory status. Decreased muscle strength. So, how fast will they fatigue with, some respiratory effort that's a little exaggerated in the postoperative period. We see this a lot currently with our COVID-related type patients, because as they're more advanced in age, sometimes they fatigue and tire a little easier. Blunted response to hypercapnia and hypoxia. Renally, they have decreased renal blood flow, decreased tubular function, and decreased renin and aldosterone responsiveness. And they also have impaired potassium excretion. Metabolic and endocrine. So they have their peak weight at 60 years of age. 15% are diabetic at age 70, and they have an increased insulin resistance as well. But GI and functional. Liver mass and blood flow has declined, so they have a decreased hepatic function, and that leads to a reduced biotransformation and albumin production. And so you think about the metabolism of our medications, well, you have some delays in that. Even their polypharmacy that they're on could have some interaction as far as inhibiting, CYP3A4 or CYP2D6. They could have decreased plasma cholinesterase. We have to assess for malnutrition or be heightened alert for it. That's an albumin level less than 3, unintended weight loss, and a BMI of less than 18.5. What about the nervous system? They could have a decrease in cerebral blood flow, about 10 to 20% reduction. They have reduced neurotransmitter synthesis, which leads to this. They also have a decreased MAC. And basically, after the age of 40, they have a reduction from 4 to 6% per decade. And that's it's pretty well known, pretty well established decrease in MAC. Increased spread with epidural. That might be kind of a new concept when you think about regional anesthesia and you're placing, let's say a thoracic epidural for some sort of postoperative pain relief, you have an increased spread in your epidural with that. You should make note of that. Postoperative cognitive dysfunction. POCD is diagnosed by neurobehavioral testing. Delirium is much more of a clinical diagnosis, kind of a state of confusion or a state of dysfunction noted. It's estimated that postoperatively 30% of our geriatric patients demonstrate some sort of abnormal neurobehavioral test score. The problem is we're unsure if it was present preoperatively. And that's why we started off with a solid preoperative assessment to kind of get some sort of baseline. And then we can notice or assess for some kind of change in their neurobehavioral scores. So more on postoperative cognitive dysfunction. It's likely multifactorial. It's drug effects, pain, underlying dysfunction, hypothermia, and metabolic disturbances. So roughly about 10 to 15% of our patients that are over 60 have this noted for about 3 months postoperatively. So when you think about enhanced recovery after surgery protocols, aiming to decrease opioid consumption, decrease their pain, certainly could help in these geriatric populations with postoperative cognitive dysfunction. And I always think to myself, what is the perfect storm for a geriatric patient, for postoperative cognitive dysfunction? It's perioperative. I mean, we give them medications that will alter their sensory. We give them an excellent source for pain. They had an operation. We put them in an unfamiliar environment, and we sleep deprive them. We wake them up every few hours, check their vital signs, check on them. It's really the perfect storm for postoperative cognitive dysfunction. Some predisposing and precipitating factors for delirium after surgery. There's a whole host of them that basically as their age increases, some of their demographic data, male gender, comorbidities. Do they have an underlying mild cognitive dysfunction? And they have dementia, preoperative memory complaint. Also, if they have some sort of cerebral vascular disease, where maybe a prior stroke or TIA, diabetes, hypertension, atrial fibrillation. Some of the things that, do they have a psychiatric history? Substance abuse could be one of them as well, depression, anxiety. Also, intraoperatively, what type of surgery are we doing? And I mentioned hip fractures in the very beginning. I mean, clearly, hip fractures are very common. Cardiac surgery, vascular surgery, those are pretty decent sized surgeries for these patients and could be associated, or it is associated with delirium after surgery. The complexity of the operation, how long of a surgery is it? What was their blood pressure like during the surgery? Was it hypotensive? Was it emergency surgery? They have decreased cardiac output throughout the procedure. What's their intraoperative temperature? Do they suffer from hypothermia? Do they receive benzodiazepines, propofol, blood transfusions? And some other anesthesia factors could include type of anesthesia. Is it regional anesthesia versus general anesthesia? The duration of the anesthetic. Obviously, the longer we're back there, the more likely to have some cognitive decline. And cognitively active medications. Are we altering that through pharmacologic agents? Postoperatively, early complication of the operation. Let's say everything went great, and now they have a complication. That's going to add to the likelihood of them having some sort of delirium postoperatively. Again, think about substance abuse, such as like alcohol withdrawal, and the postoperative period. More precipitating or predisposing risk factors for delirium: age greater than 65. We talked about being a male, having a history of dementia, cognitive impairment, depression, functional impairment, history of falls. And I always ask patients that, when they come in for the PAT clinic for like a total knee arthroplasty or total hip, I ask them, how many times have you fell in the last 6 months? And it's a surprising number. I think most of the literature quotes like 40% of total knee patients fall preoperatively. And quite a few patients do fall. And certainly their family, if they're present, validates that with us. Malnutrition. If they have a poor nutritional status preoperatively, that's a predisposing factor. Severe illness, sensory impairment. Can they, how's their hearing and vision? Fracture or trauma. And are they being treatment with multiple psychoactive medications. Precipitating factors is as us, if we allow them to get dehydrated, do we give them opioids, treat with multiple drugs, do we give sedatives, hypnotics? So we play a pretty big factor in that. Use of a bladder catheter, physical restraints, alcohol and drug withdrawal, hypoxia, infection and pain. So you can see the anesthesia world, as we think about geriatric anesthesia, it's not really just the intraoperative portion. It is, we clearly have a lot to add or subtract from that scenario. But think about what we prepare them preoperatively. Can we do enhanced recovery after surgery protocols? Can we do more regional anesthesia, decrease their reliance on opioids postoperatively, the need for a bladder catheter, for example? Can we help them in that scenario avoid urinary retention? Certainly hypoxia, allow them to take a deep breath and have proper respiratory functions postoperatively could be related to, maybe a properly managed intraoperative anesthetic with a good postoperative analgesic course, either maybe applying some sort of regional anesthesia, something that's going to decrease opioids and allow them to breathe properly without interference from pain related to their surgical procedure. Dehydration, clearly we're the fluid folks. It's nice if you have some sort of dynamic monitor to make sure that you're properly hydrating these folks and optimizing their cardiac performance. So I think we have a lot to add to this scenario, hopefully more positive than negative. So about prevention. As part of enhanced recovery after surgery protocols, or that team that's looking at, how can we improve patient safety, improve their efficiency, their patient experience. And we could be part of those processes within your institutions. And one to really think of it is how many geriatric patients are we working with daily, and how can we prevent some postoperative delirium, which is going to be very concerning for the patient and also the healthcare system. It's going to delay their discharge and their family. It's going to be pretty concerning for them to have their loved ones stay in the hospital longer than they want, and also experience postoperative delirium. How can we prevent that? Is orientation clocks and calendar. I have a little bit of experience with this. I have my geriatric parents living in my basement for about a year and a half. They're in their late 70s, 77 and 75. And just prevention of confusion and delirium on a daily basis is having an orientation clock. What time is it? And what's the day of the week? And what day is it? That's helped out drastically. So I speak from personal experience that this stuff does work. Secondly, glasses and hearing aids. They have some hearing impairment, and we struggle with that. It is extremely difficult to communicate people that are unable to hear you and unable to see properly. Early mobilization and rehab. No polypharmacy. And I mentioned ERAS protocols, which sometimes a little heavy on the polypharmacy. And I would say that as you get into the geriatric population, think of, maybe gabapentin isn't a good option for these folks that, at an age greater than 65 or 70. Be very cautious with, non-steroidal anti-inflammatories or COX-2 selectives with their renal function. So while you're giving multiple agents, make sure it's targeted and that you really tailor it to those patients, patient populations. Pain management protocols. We have, I think, roughly 30 ERAS protocols within our facility. And one of the things is really how can we decrease postoperative opioids and really take care of their pain properly and efficiently, and really decrease the amount of cognitive dysfunction and opioid related complications for these folks. Normal electrolytes, and make sure they have some sort of protocol looking for postoperative complications in the geriatric patient population. And again, anesthesia providers, we have a huge role in this. Everyone does, anywhere from the person checking them in to make sure they're escorted to the proper location, to RNs caring for them on the floors. Everyone has an active role in this, and certainly should be a valued member of the team. Musculoskeletal systems. They have a reduced muscle mass, skin atrophies, they have frail veins. Anyone started several IVs on the geriatric population, you know that they blow easily, if you will. So frail veins is something to consider. And I would really, we advocate if they're going to stay in the hospital for a few days. I think the magic number is more than 2 days or 3 days, 72 hours. It's nice to have more of a definitive IV. Maybe put in an IV that's, in a position that's easily tolerated. Like upper in the basilic vein in the upper arm, a longer catheter that could stay in for a few days, more reliable IV access that could help the patient population as well as the nursing staff to have reliable IV access. Arthritic joint issues with regional anesthesia and positioning. This is a big one. You want to do a regional anesthetic, but is it really practical in their arthritic state? Can you actually position them properly for this? The other is with positioning during the operation. Make sure that you're properly padding these folks, and in fact, not dislocating one of their joints. So we have to be extremely careful with positioning, even under general anesthesia. Neck mobility could be a potential for difficult airway. We started off with airway, and we mentioned advanced age could be it is a potential predictor of difficult intubations and mask ventilation. And so here we are, neck mobility for the musculoskeletal system. Okay, some studies about, undergoing orthopedic surgeries and total hip arthroplasties, total knees, and cardiovascular surgeries. I looked at what is the incidence of delirium and what's its effect. It's a negative hospital outcomes. It's a 10-fold increase in death if they have delirium postoperatively, a 5-fold increase in nosocomial infections. I find that to be extremely alarming, and it deserves the anesthesia provider's attention that we could actually help out in this area. Poor 1-year functional recovery and postoperative cognitive decline. They come in one level of function and they leave in a worse state. And so sometimes with emergency surgery, hip fractures, obviously it wasn't planned, but with elective surgery, we should really consider this as far as our risk stratification. What is the chance, if you will, of having a decline in their functional status postoperatively? Short-term cognitive decline seen in some patients after development of delirium is similar to Alzheimer's patients. And so that's concerning. I've had many patients that are, 7th, 8th decade, when they come into the pre-anesthesia testing clinic, they're really concerned about their cognitive decline. They want to know, it's almost like they're assessing my knowledge level of, are you aware of the literature related to postoperative cognitive dysfunction? And are you, do you have measures in place to try to prevent that? And so we do, and certainly we give that lots of attention in the perioperative period. Also, with reports up to 50% of patients over 60 years old developing postoperative delirium following cardiac surgery. That's going to be a big concern for these folks coming in for cardiac related surgeries. Age-related pharmacological changes. Again, this is another area that could potentially be on your board exam or CRNAs for your reboarding exam. Hopefully this is somewhat helpful. They're sensitive to centrally acting anticholinergic agents like scopolamine and atropine. When you think about, everyone gets postoperative nausea and vomiting prevention, be a little careful with that. Maybe scopolamine wouldn't be the best option for some of our geriatric patient populations. Reduced volume distribution and reduced water content. So they will have an increase in plasma level. Increased volume distribution from lipid-soluble drugs. They'll have a decline in renal and liver elimination. So if something is, excreted unchanged via the kidneys, and if they have a decline in renal function, you're going to have a prolonged duration for that patient. If something is a prodrug, you could have, maybe they won't activate the drug very well. The other side of it is if they have decreased biotransformation via the liver, maybe they will not metabolize that medication properly, and they'll have a prolonged duration of action. So we should really assess for that and really change our anesthetic management related to that. Reduced anesthetic requirements, again, 4 to 6% for every decade over 40. So how does one, titrate your general anesthetics, inhaled agents? maybe this is an excellent source for our an impetus to basically do cognitive monitoring in the perioperative period. Certainly make sure that you're giving an adequate dose and that you're not underdosing your patients with inhaled agents or overdosing them. That could be some sort of assistance to the anesthesia providers. What about inhaled anesthetics? Again, you have a faster onset of the inhaled agent. So if you're doing an inhalation induction, if the cardiac output is depressed, it's a prolonged recovery due to this increased volume distribution with the lipid soluble medications and also decreased pulmonary gas exchange. So you're kind of going to have, and just sticking to the strict inhalation agent, and your basics pharmacology class or anesthesia, they may have told you that inhaled agents take longer if the cardiac output is fast. You have a faster onset if the cardiac output is decreased. This is just highlighting this fact, could be in this patient population of geriatric patients. But it's important to know that recovery could be increased, prolonged due to an increase in volume distribution. So as those inhaled agents are redistributed into the lipid space, if you will, those soluble agents will be there and come back into the plasma and basically keep your plasma level up. So we could have a prolonged recovery from that, and also decreased pulmonary gas exchange as well. Sorry about that. Non-volatile anesthetics, you have a lower dosage of propofol. You should reduce your propofol, etomidate, opioids, and benzodiazepines by 50%. Propofol, you have a higher incidence of apnea and hypotension. So when you think about monitored anesthesia care, this could be an issue. Single dose of ketamine, 0.5 milligrams per kilogram, is suggestive to reduce the incidence of delirium. Should have caution with Parkinsonian patients and anti-nausea agents with anticholinergic and anti-dopaminergic properties. And so again, as you think about your postoperative nausea and vomiting, with some of your ERAS type protocols, be very cautious with some of your anticholinergic and anti-dopaminergic agents. Dexmedetomidine is a good choice for these folks. Muscle relaxants. There's no alteration in succinylcholine, but there is a twofold prolongation of the onset due to decreased cardiac output and reduced blood flow to the muscles. And so we think about cardiac output and perfusion to the areas of the target site. We're going to get a prolongation there. It's going to take a little longer for its effect. Decreased clearance with reduced renal and hepatic function. If your non-depolarizer of choice is relying on that for metabolism or clearance, you certainly could have a decrease in the clearance related to renal and function impairment. General versus regional anesthesia. This is basically just a summary of kind of a multiple studies they reviewed. They looked at 6,700 patients, roughly. 32 studies were analyzed, and there was only moderate evidence of nearly 2 times greater probability of postoperative delirium for those aged over 80. So that was kind of the big hallmark. The general versus regional really didn't show much of a difference with that. But if someone was over 80, that seemed to have a very large correlation with having postoperative delirium. If they had patients that were in care, institutional care pre-admission, so let's say they're in an assisted living or nursing home, they had a 6-time probability of developing postoperative delirium than the other folks. So again, this is just validating some of those risk factors, but the general anesthesia versus regional, it's not quite, there's just really lacking evidence that one's superior over the other. So, all right. Well, thank you guys for coming to our podcast on WeNap. Hopefully this geriatric anesthesia small overview is helpful, and I look forward to having another podcast soon. Take care and have a safe day.